Okay, guys, I'm going to briefly explain the physiologic effect of sympathomimetics that is seen in the USMLE textbook, step 1. It is very confusing, but I'll try as much as possible to break it down for you to understand it. You don't need to cram anything. If you follow these steps, you don't need to cram it. It's just understanding the basic. Now, first of all, the drugs we are talking about here, we have norepinephrine, epinephrine. We have epinephrine, and we have isoproterenol. Okay, we are talking about these drugs, these guys. So before I proceed, I will draw your attention to what you already know. These drugs act on these receptors. We have alpha 1, alpha 2, alpha 1, alpha 2, beta 1, beta 2. Okay, these are the receptors this drug acts. So norepinephrine and epinephrine act on alpha 1 and on alpha and beta, but the effect differs based on the receptor. Isoproterenol act only on beta. The effect on beta 1 and beta 2 are the same. So, but before we proceed, we already know where we find alpha 1. We find that on vascular smooth muscle, visceral smooth muscle. If seen on vascular smooth muscle activated, it causes vasoconstriction, and that will lead to increase in peripheral resistance. Seen on visceral smooth muscle on the skin, that will lead to constriction, and that will lead to channeling of blood to vital organs, especially during shock or blood loss. So alpha 2 receptor is seen on, we see them in pancreas, presynaptic terminals, synaptic terminals, salivary glands. So if you see on presynaptic terminals, this guy would inhibit neurotransmitters. So you have, for example, presynaptic terminal like this, presynaptic vesicle. You have receptor, presynaptic receptors. So this alpha 2, this is where neurotransmitters bind, epinephrine, dopamine, whatever. So these guys would inhibit the neurotransmitters. This is synaptic cleft, and this is a postsynaptic cleft, have receptors. So that's why the uptake inhibitors can inhibit this drug acting on alpha 2, because drug acting on alpha 2 will inhibit the release of neurotransmitter from presynaptic receptors into the synaptic cleft, making them unavailable. Understood? So beta 1, we see beta 1 in the heart, kidney. So heart, they causes increase in heart rate, increase in cardiac contraction. So kidney, this guy will cause increased renin secretion. An increase in renin secretion is a result of decreased blood flow to the kidney, juxtaglomerular apparatus specifically, and then decrease in GFR. Okay, so this guy, beta 2 receptor, you can see them in the cardiac muscle, muscle. So they cause cardiac contraction. For instance, there. You see them in the bronchioles. Bronchioles. They cause bronchodilation, 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 bronchodilation. Don't forget, so drug that acts here like salbutamol, albuterol, used in COPD and asthma. The effect is to dilate the bronchos so that the person finding it difficult to breathe will breathe, and also if there's an increase in mucus secretion, they can also help. Then you can see this guy also in the liver. So when activated, it causes inhibition of insulin secretion. That makes a lot of sense. You see this guy also in the visceral smooth muscle. So, but the effect here in the visceral smooth muscle is dilatation, vasodilatation. Okay, let's go back to what we are talking about. So, norepinephrine effect is norepinephrine acts on alpha more than the way it acts on beta. So epinephrine acts on beta more than the way it acts on alpha. As for proretanol, the effect on beta 1 is equal to the effect on beta 2. Now, what they check, the parameter they check in when they want to test for these drugs, one of them is cardiac output. Second one is heart rate. Another one is mean atrial blood pressure, mean atrial pressure. Another one is pulse pressure. Okay, let's go back to breaking this down. Ladies and gentlemen, cardiac output is equals to heart rate times stroke volume. Stroke volume is equal to end systolic volume minus end diastolic volume. That makes a lot of sense. You don't need to forget it. I'm taking it step by step so that you don't need to cram anything. So another one we need to know is mean atrial pressure is equals to 1/3 pulse pressure plus diastolic pressure. And pulse pressure, ladies and gentlemen, is equals to systolic pressure minus diastolic pressure. That makes a lot of sense. In other words, you can say mean atrial pressure is equals to 1/3 in brackets systolic pressure minus diastolic volume of pressure, whichever one you want to. Okay, that is it. Let's go back to what we want to do. Okay, let's draw the first line for the first graph. Let's call this blood pressure. And the blood pressure we are talking about here is we're talking about systolic, diastolic pressure, and mean atrial pressure, right? Okay, let's draw the second line for the second graph. We'll call this guy heart rate. Okay, let us draw the last one. We call this guy peripheral resistance. Okay, that makes a lot of sense. Now, remember we said that if we have seen or we know that effect of norepinephrine on alpha receptor is greater than beta receptor. And alpha receptor activation, based on what we see here, the location of alpha receptor is on vascular smooth muscle and visceral smooth muscle. So if you activate it in alpha receptor in the vascular smooth muscle, it will cause vasoconstriction and lead to increase in peripheral resistance. Ladies and gentlemen, so since the effect of norepinephrine is greater on alpha than beta, so we are going to expect an increased, we'll call it an increased peripheral resistance. We'll call it unopposed peripheral resistance. You can call it anything you like, but just know that peripheral resistance is increased. And we know that peripheral resistance is responsible for diastolic volume. If there is increase in peripheral resistance, you should expect increase in diastolic volume. So we have diastolic pressure, rather. So you should have an increase in diastolic pressure. This guy. That makes a lot of sense. Now, if this is the case, what do you think the heart will do? Do you think there will be an increase in heart rate or decrease in heart rate? The effect of norepinephrine is more on alpha. It doesn't mean that there's no effect on beta, and beta is located in the heart. Beta receptors, you see them in the heart, but beta 1 and beta 2. So, but see what since the beta is there in the heart, systolic volume is also going to increase. And if systolic volume increases mean atrial blood pressure, diastolic volume increases, mean atrial blood pressure is also going to increase, because it is the difference of this plus diastolic one third of the difference between systolic and diastolic, plus the diastolic will give you mean atrial blood pressure. If you calculate it, you should expect an increase in mean atrial blood pressure. So mean atrial blood pressure will increase. Now, what should you expect to see on the heart rate? Do you expect it to increase or decrease? That is the question. So this is where we increase peripheral resistance. If the heart, because there's a reflex mechanism the heart will use. If the heart allows the heart rate to increase without controlling it, that will be very, very dangerous effects of this drug in the heart. So what the heart will do is that, and the effect of alpha is more when you use this drug, the heart will cause what is called reflex bradycardia. So here you should expect reflex bradycardia, because cardia, not because only that norepinephrine acts more on alpha than beta. Nope. It is because the peripheral resistance is way increased. So the heart will try to balance it. And the peripheral resistance is increased as a result of alpha 1 activation in the vascular smooth muscle. That makes a lot of sense. Please don't cram this. This is, if you follow my step, you will understand this. Now let's go to epinephrine. Okay, but before we go to epinephrine, let's check the parameters. Cardiac output is stroke volume times peripheral times what? Stroke volume times heart rate. And we see that heart rate is decreased. Stroke volume is end systolic minus end diastolic. So what we are going to see here is that since the systolic is increased and diastolic and systolic over and diastolic, that is the stroke volume. So since the systolic is increased here, and then we have the the diastolic increased and heart rate decreased. So we have heart rate decrease, systolic increase. So cardiac output is heart rate times systolic volume. This will cancel this. So we have normal cardiac output. Unchanged, you won't have it, it will not change. So heart rate, as we have seen here, is decreased. Mean arterial blood pressure here, we have seen, is increased. Well, we increased. Pulse pressure here is increased. So let's move to epinephrine. The effect of epinephrine on beta is higher than on alpha. So it acts more on beta than alpha, in other words. So if you act more on beta than alpha, so what do you expect the peripheral resistance to be? What causes peripheral resistance to increase is alpha, and they act more on beta. So you should expect peripheral resistance to decrease, not way decrease, because it still acts on alpha. Because the effect is greater. So that is it. Now, what do you expect the heart rate to be? The heart rate should increase because is beta. Beta is responsible to, beta 1 is responsible for heart rate. So what do you expect systolic volume to be? Systolic volume should also increase. So what do you expect diastolic volume to be? So since the effect of beta is greater than alpha, in terms of diastolic volume, beta 2 is what you should be looking at, and alpha. So alpha is responsible for diastolic volume because alpha is responsible for peripheral resistance, which is responsible for diastolic volume. So since the effect is decreased, you should expect diastolic volume to decrease. And if that is so, what do you expect the mean atrial pressure? This is increased and this is increased. Mean atrial blood pressure should increase slightly. The difference, if you calculate it, it should increase, but not remarkably. So that is it. I said don't cram this. It's simple if you follow this. Now let's go to isoproterenol. The effect of isoproterenol on beta 1 is equal to the effect on beta 2. So in other words, isoproterenol has equal effect both on beta 1 and beta 2 receptors. So if you use this drug, it can act both in the heart, cause increase heart rate, cardiac contraction, acts also in the bronchioles, bronchodilation, act also in the liver, inhibit insulin, act also in the smooth muscle of the viscera, causes dilatation. So these are the things we need to know. And also act in the heart. Beta 2 act in the heart, cause cardiac contraction. Now, if there is no effect, the isoproterenol does not even act on alpha at all. So you shouldn't even be thinking about increase in peripheral resistance. So peripheral resistance is going to drop, way drop. And then because it acts, the effect on beta 1 and beta 2 is the same. So because it's drop, so it drop way down. So the heart, there would be a reflex tachycardia. So the heart rate is going to increase. Two reasons why the heart rate is going to increase here is because this drug acts only on beta. Second reason is because the peripheral resistance is dropped. So a reflex will make the heart to increase heart rate. So you have here reflex tachycardia. So what do you think would be the diastolic? Remember, preferential resistance is responsible for diastolic. So preferential resistance is decreased. So diastolic is going to will also decrease. So systolic volume or systolic pressure is as a result of activation of beta 2. So it's going to increase. If it's going to increase remarkably, and this one is going to decrease, diastolic is going to decrease remarkably because there is no even alpha at all, you should expect a slight decrease in mean atrial pressure. Now, let's go back to epinephrine and look at the parameters. So remember, we have cardiac output, heart rate, mean atrial pressure, pulse pressure. So cardiac output is stroke volume times heart rate. If you look at this epinephrine, heart rate is increased, stroke volume is increased. So you should expect cardiac output to increase. Heart rate, you should expect it to. Mean atrial blood pressure, as you can see here, it is increased. Pulse pressure, which is different between systolic and diastolic, should also be increased. Okay, come to isoproterenol, where we don't have alpha effect at all. So, and we see that peripheral resistance here is decreased. And the cardiac output is heart rate times stroke volume. So you should expect cardiac output to way increase because there's a reflex tachycardia here. So cardiac output will be way increase. Heart rate will also way increase as a result of reflex tachycardia. So what is the mean atrial pressure? So mean atrial pressure is going to decrease. This is only drug that among these sympathomimetics that causes decrease in mean atrial pressure. So it does mean that any agonist of this drug would cause decrease in the mean atrial pressure. So don't forget that. Now, let's look at the pulse pressure. The difference between systolic and diastolic. Of course, you expect it to be well increased. Ladies and gentlemen, this is what I can provide so that you can be able to understand this physiologic effect of sympathomimetics. You don't need to cram it if you follow it this way. Thank you.